Okay. So we have just a few more a few more topics to finish up electrocardiography. Uh, what we're going to do now is use the ECG, EKG to determine chamber enlargement. Okay, so you can look at the ECG, the surface ECG, and determine if the left atrium, the right atrium, the left ventricle, the right ventricle is enlarged. All right, so that's what we are going to teach you to do. Now, the first chamber we're going to look at is the left atrium. So you can determine left atrial enlargement by just looking at the surface ECG. And one of the best way to do this is to look in lead V1. Look in lead V1. If lead V1 is biphasic, and I'll explain what that means, and if the terminal portion of that biphasic uh, P wave, so if the P wave in lead V1 is biphasic, and if the terminal portion of that P wave is more than one small block in width and one small block in height, then if those criteria are there, then you have left atrial enlargement, and we'll show you what that looks like. Okay. Also, if you look in your inferior leads, that is your leads 2, your leads 3, and AVF, and if you have notch P waves, more than likely you have left atrial enlargement. But the lead V1 criteria is what most people use. So it looks somewhat like this. All right. So if this is in lead V1, so of course, this is your T wave, it's inverted. Then this is your P wave, and then your QRS complex. So if you look on your P wave, looks something like this. So you have an initial portion of the P wave which goes up, and the terminal portion of the P wave goes down. This is what we call the terminal portion, okay? So if this terminal portion, which goes down, is more than one tiny block in width, so the width, if the width of it is more than one tiny block and the depth is more than one tiny block, then that is a left atrial enlargement. So as we said, the terminal P negativity in lead V1, the duration should be greater than or equal to 0.04 seconds. So remember, 0.04 seconds is 40 milliseconds, and the 40 milliseconds is one tiny block in duration. And then if we say the depth greater than or equal to 1 millimeter, then it's the height of it is one tiny block. So again, lead V1, if you have a biphasic P wave, so the P wave portion goes up and a portion goes down, and if the terminal portion, the width of it, or the duration is more than one small block, so the duration will be more than 40 milliseconds, and then the height of it, if it's more than one tiny block, it's more than 1 millimeter, because the height of each small block is 1 millimeter. So this would satisfy your left atrial enlargement criteria. Now, if you look in the inferior leads, so again, the inferior leads are your leads 2, your lead 3, and AVF. And if you have a biphasic P wave, so you can see that the P wave have two humps. So that's why we call it biphasic. So if you have two humps in your inferior P waves, then that's left atrial enlargement. Now for right atrial enlargement, you look also in the inferior leads, but the most common lead we use is lead 2, but you look in the inferior lead, and then the height. So you usually get giant P waves, big P waves. So if you're looking lead 2, and if the height, now we're talking about the height, not a biphasic, but the height of the P wave, if it's more than 2.5 millimeters, then you will have right atrial enlargement. So let's look in, so inferior leads 2, lead 3, and AVF. Just check the height of these P waves, okay? And you can check it. Remember, one tiny block is 1 millimeter. So if you get in something looking like 3 millimeters, that's definitely right atrial enlargement. So giant P waves in the inferior lead, especially lead 2, is suggestive of right atrial enlargement. Okay, so we look at left atrial enlargement, we look at right atrial enlargement. Let's look at left ventricular hypertrophy. We see a lot of EKG coming in, patient coming in for ECG, because of left ventricular hypertrophy. The EKG is not very specific for this entity, but we still use it. We use it, and if it's present on the ECG, we report it. The best technique or test to look for left ventricular hypertrophy, however, is your echo cardiogram, your echo. But when we talk about left ventricular hypertrophy, we're talking about thickening of the LV wall. We're talking about the myocardium is thickened. That's left ventricular hypertrophy. Okay, and we usually refer to the voltage criteria, and what we mean is when you have left ventricular hypertrophy, the voltage is going to be very high. Okay, the voltage is going to be very high in your when you do your ECG. So there are a number of criteria that is out there. The one that we tend to use mostly is the Estes criteria. But all of the criteria are voltage, mainly voltage. So when you look in your limb leads, so you know your limb leads is your lead 1, your lead 2, 3, AVR, AVL, and AVF. Those are your limb leads. So when you look in your limb leads, if you have any R or S which is greater than 20 millimeter, remember the height of each tiny block is 1 millimeter. So if the R, which is, you might remember the R is the positive deflection, and then S is the negative deflection. So if you have a R or an S in the limb lead, which is greater than or equal to 20 millimeter, more than likely, you're gonna have left ventricular hypertrophy. If you also look in lead V1 and V2, and if the Hess, remember the Hess is the downward deflection, if that Hess in V1 and V2 is greater than or equal to 30 millimeter, you more than likely have left ventricular hypertrophy. So most of the criteria you're going to use is voltage. When you say large voltage, think in terms of left ventricular hypertrophy. Again, when you look in lead V5 and V6, the R wave, so the upward deflection, if it's more than greater than or equal to 30 millimeters, more than likely you're going to have left ventricular hypertrophy. So if you have these voltage criteria and you also have left atrial enlargement, remember for left atrial enlargement, the best lead is probably lead V1. And if you have a terminal P negativity, which is more than one tiny block in width and more than one tiny block in height, you more than likely have left atrial enlargement. So if you have these voltage criteria plus left atrial enlargement, your chance of having LVH is very, very great. Also, if you have left axis deviation, okay? Usually when you have left ventricular hypertrophy, it gives you left axis deviation. We went over the definition of a left axis deviation. And also when you look in the QRS, the duration, the QRS duration is usually greater than 0.09 seconds or 90 milliseconds. And we talk about STT abnormalities with left ventricular hypertrophy, or we call it a strain pattern. So left ventricular hypertrophy with strain. So if you see a strain pattern, and a strain pattern, I'm going to show you what that looks like. But a strain pattern is when you look in your lead V5 and V6, you get a little bit of ST segment depression and T wave inversion. That is because, when you have left ventricular hypertrophy, the LV comes on the strain. So if you have a few of these present, you're going to have left ventricular hypertrophy. And what Estes did, he used a number system, and he combined all of these. And if you have a certain number, you definitely have LVH, and then probably LVH, that type of thing. So you can look in the Estes criteria, but in essence, if you have big R or S waves, okay, so if you look in your limb lead and you have big R or S waves, more than equal to 20 millimeters. If you look in V1 and V2 and you have deep S wave, greater than equal to 30, and you look in V5 and V6, if you have big R waves, greater than equal to 30 millimeters, also supporting evidence is your left atrial enlargement, left axis deviation, QRS duration, that's the width of the QRS, all right? If it's more than greater than or equal to 0.09 seconds, or if you have STT abnormalities. So I'm not sure how well this is projecting, but let's look and see what we have here. So look in V5 and V6. So V5 and V6. So we have big R waves, and you can count it. Each big block is 5 millimeters. So we have 5, 10, 15, 20, 25, close to 30. And in V5, you have 5, 10, 15, 20, 25, close to 30. So you have some voltage stuff going on there. But look here, look in V6. The ST segment is a little bit depressed, but you definitely have T wave inversion. This is what we call strain. So strain is sort of specific for LVH. A strain pattern is clinching the diagnosis for left ventricular hypertrophy. So it is you get a slight ST segment depression and T wave inversion, usually in V5 and V6 or the V6 alone. Okay. Again, a left axis deviation. So if you look at your axis, the most isoelectric in your limb lead is lead 2. Perpendicular to lead 2 is AVL. AVL subtends an angle of -30. So this is the left axis. So we have a little voltage thing going. We have a left axis. And if you look closely in V1, you can see that the P wave, there's a terminal negativity. There's a terminal negativity. And if you look closely, you can see that the width of this terminal negativity is more than one tiny block. So the duration is greater than 40 milliseconds. And then the height is more than one tiny block, which is more than 1 millimeter. So you have left atrial enlargement, you have this voltage, and you have left axis deviation. When you add these things up together, you can call this left ventricular hypertrophy. All right, so get in the habit of when you get an ECG to try and read it. We went over all the basic criteria for you to read the ECG. Okay, so try and read it. Now we look at left atrial enlargement, we look at right atrial enlargement, we look at left ventricular hypertrophy. Let's look at right ventricular hypertrophy now. So again, we have voltage criteria for right ventricular hypertrophy, but they're different. With right, we call it RVH, with right ventricular hypertrophy, when you look in lead V1 and V2, you're going to get big R waves. Big R waves in V1 and V2. You will also have a right axis deviation. And if the right ventricle is hypertrophed, then it's going to put pressure in the right atrium. So you'll also get right atrial enlargement. So usually when you have right ventricular hypertrophy, you have big tall R waves in V1 and V2. You have a right axis deviation. We went over how to determine axis. And then you also have a right atrial enlargement. That is, when you look in your inferior leads, especially lead 2, you're going to get giant P waves. Those P waves are going to, the height are going to be greater than 2.5 millimeters. So this would be a case of right ventricular hypertrophy. So in lead V1 and V2, if you've been looking at EKG, you know that this is not normal to have big R waves. Usually what happens, the R wave gradually get larger and larger when you move across the chest. So the R wave in V1 is usually tiny, V2 a little bit bigger, V3 a little bit bigger, V4 bigger. That's a normal thing. The R wave gradually gets larger as you move across the chest. But when you have right ventricular hypertrophy, you start out with big R waves in lead V1 and V2. And when you look in your lead 2, this doesn't show it very well, but you'll get giant P waves. You get giant P waves in lead 2. And then you'll also have right axis deviation. So we can look at this axis, okay, and see if we have right axis. The most isoelectric, okay, you can call it lead 2, okay. When you look in your limb leads again, okay, limb leads are lead 1, lead 2, lead 3, AVR, AVL, AVF. So if we say lead 2, okay, if lead 2 is the most isoelectric, and that is the positivity equals to the negativity, perpendicular to lead 2 is AVL, AVL. So AVL is perpendicular to lead 2. But you can see AVL is negative, okay? AVL is negative. A positive AVL is minus 30. So a negative AVL is plus 150, okay? All right, so if you don't have your cheat sheet to follow, I mean, I tell you, always walk with it. So if you're not walking with it, then okay, the most isoelectric limb lead is lead 2. Perpendicular to lead 2, AVL. AVL is negative, however. Positive AVL is minus 30. So negative AVL is plus 150. So that's right axis deviation. Anything greater than your 120 and greater is right axis. So we have big R waves in V1, V2. We have right axis deviation. Um, we really don't see giant P waves there, but at least we have those two criteria. And then a very powerful criteria. This is actually RVH with strain, right ventricular hypertrophy with strain. Same thing that you'll get in LVH. You get a little bit of ST segment depression and T wave inversion. ST segment depression, T wave inversion. So this is RVH with strain. So, that makes it more specific for right ventricular hypertrophy. All right, so we have looked at chamber enlargement, look at left atrial enlargement, right atrial enlargement, left ventricular hypertrophy, right ventricular hypertrophy. We're going to look at something else. We're going to look at acute pericarditis. Uh, Acute pericarditis is inflammation of the pericardium, and patients usually present with sharp stabbing chest pain. This is a very intense stabbing pain, usually very intense when you lie flat, and patient will tell you they get relief when they sit up. Okay, when they sit up and lean forward, the pain is better. Okay, acute pericarditis, right? So it's inflammation of the pericardium, and the ECG is classic. The ECG is classic. So when you're doing any type of test, you'll get an acute pericarditis. So you're going to get widespread ST segment elevation, but the ST segment elevation is going to look different from your heart attack. So remember, you can get a heart attack with ST segment elevation. The ST segment elevation with acute pericarditis looks different. You're going to get ST segment elevation in all the leads except AVR, and V1. So when you get a heart attack, the heart attack is usually inferior or anterior lateral. You're not going to get a heart attack involving the whole heart. That it doesn't work like that, because you have different blood vessels, and not all the blood vessels going to close off at the same time. So sort of common sense type of thing. You're not going to get all the blood vessels closing at the same time to give you a heart attack involving the whole heart. It doesn't work like that. But when you have inflammation, all the pericardium will get inflamed. Okay, so that is why you have the widespread ST segment elevation, and the for the heart attack, the ST segment usually looks like that. It usually coves up like that. Okay, so this is your so your ST segment for a heart attack gonna look something like that, as opposed to your ST segment for a pericarditis is gonna like that. So we say it's concave. Okay, so it is concavity. It it dips in, whereas your heart attack, it's they talk about the tombstone. Okay, so it bulges out. So again, widespread ST elevation in all your leads except AVR and lead one V1. In your AVR and V1, you get PR depression. So the PR segment is depressed. And usually, if it's acute pericarditis, you're going to have a tachycardia. So you'll have sinus tachycardia. So widespread ST segment elevation, and except your AVR and V1, where you get you get, instead of ST elevation in AVR and V1, you get elevation of your PR segment in those leads. I'm going to show it to you, okay? I'm going to show it to you. You're going to get PR elevation, and you tend to get PR segment depression in all leads except AVR and V1. I'm going to show it to you because just talking about it might be confusing you. All right, so this is so when you see something like this, never call it an acute heart attack. The treatment is different. If you treat this patient with thrombolytics, you're going to kill this. This patient will be dead. All right, so and you can see that the ST segment is elevated. The ST segment, but looking, it's concave. There's a little concavity there. You see, there's a little concavity, So it sort of dips in, Okay, you see this one? It dips in. Okay, but you have ST segment elevation in all the leads except AVR and lead 1, where the ST segment is depressed. The ST segment is depressed. It's not elevated, but you're going to have PR segment elevation. So the PR segment is elevated in AVR and V1. But if you look in all the other leads, you're going to get PR depression. The PR segment is going to be depressed. In the leads where you have ST segment elevation, the PR is going to be depressed. Okay, look at there. The PR segment is depressed. The PR segment is depressed. Except in AVR and V1, the PR segment is elevated. Okay, so acute pericarditis, sharp stabbing chest pain, sometimes it goes to the back, sometimes it goes to the shoulder. The patient is worse if they lie flat. They get a relief when they lean forward. They may have a white cell count when you do the blood test. They might have a temperature. They behave different. And it might be a young patient, whatever. But you have this widespread ST segment elevation. You don't usually get a heart attack involving the whole heart. So that should tip you off. And then patient usually presents with sinus tachycardia. Treatment is completely different. For this patient, you're going to give them anti-inflammatory medication along with what we call colchicine. So you'll give them an anti-inflammatory pain medicine such as aspirin, indomethacin, Motrin, along with colchicine. Whereas, with a heart attack, ST7 elevation heart attack, you're going to take them to the cath lab, you're going to put a stent in, or you're going to give them thrombolytics. Okay, treatment is completely different. All right, so we look at acute pericarditis. Now, you can also use the ECG to help you to diagnose electrolyte abnormality. And the electrolytes that we're concerned about is your potassium, your magnesium, your calcium. Okay, those are the important. Well, all the electrolytes are important, but whenever these electrolytes whether they're high or low, you can use the surface ECG to help you to make that assessment. And sometimes you have to do this before you get the blood test. Common thing, you have a patient with renal failure, comes to the emergency room, and the patient heart rate is 20 beats per minute. And when you get a quick ECG, you already take the blood and send it off to the lab, but you get your ECG and you see that the patient have peak T wave. The T waves are very, very peaked. The QRS complex is wide. The patient have a heart rate of 30 beats per minute, blood pressure say 80/40. You're not going to sit down and wait for the blood test to come back to tell you that the patient have hyperkalemia. The clinical scenario and your ECG tells you what's going on. So for this patient, you're going to treat them aggressively. We will give them insulin, we'll give them calcium to protect the heart, and give them something called Kayexalate to remove the potassium. So what you're doing is using your ECG to help you to make the assessment even before the blood test comes back. So with hyperkalemia, that is, the potassium is high, okay, usually in patients who have kidney disease, and this is so common. Some patients just, for whatever reason, they just always come in with this high potassium and their heart rate 20 beats per minute and blood pressure low. So on the surface ECG, you're going to see peak T waves. The T waves are going to be enlarged and peaked. The QT interval is going to be shortened. The QRS is going to be wide. And sometimes when you see these patients, they have wide and what we call a sinusoidal QRS complex. The P waves, the amplitude of P waves is going to be reduced. Sometimes you don't see a P wave because the amplitude of P wave is reduced to such an extent that there's no P waves. You get increase in the PR interval, significant bradycardia, and we call the sine wave pattern because the QRS is wide and there's no P waves. So again, these are what we call peak T waves. You can see, we don't usually see the P wave, the T wave this big and peaked. Okay, so these are peak T waves, and then you can see that the P waves sometimes get very tiny. Sometimes the P wave disappear. So if the potassium is high enough, the P wave disappear. You don't see any P waves, and you can get something looking like this. It looks like a ventricular tachycardia. The QRS is wide. You have no P waves, so you can get something looking like this. So these are all ECG features of hyperkalemia. And again, it can be an emergency, so you need to know what to do, how to treat these patients. Your ECG is going to help you. All right. So hyperkalemia. So if you have high potassium, you can also have low potassium. So a low potassium is also dangerous. So remember, a high potassium will give you a bradycardia. Patient comes into the emergency room, a slow heart rate. A low potassium can give you tachycardia. These patients can go into torsades, the point, and they can, that's a ventricular tachycardia, and they can die from ventricular fibrillation, okay? So a low potassium hypokalemia, low potassium, opposite to what you would get with hyperkalemia, you get a decrease in the T wave amplitude. So instead of the T wave becomes peak, it becomes very small. The ST segment is depressed somewhat. Your T wave is inverted, and this is, very common. T wave is inverted, T wave inversion, prolongation of your PR interval, and instead of you getting a small P wave amplitude, you get an increased amplitude of the P wave. You get these U waves and prolonged QT interval. This prolonged QT interval is what give you the ventricular tachycardia. And the ventricular tachycardia, we call it polymorphic ventricular tachycardia. Polymorphic because it's more than one form. And the other term for it is torsade de pointe. And these patients can degenerate into ventricular fibrillation. So again, a low potassium hypokalemia, you get these inverted T waves, and you get these U waves. So after the T wave, then the wave that comes after the T wave is a U wave. So you get these big U waves. Okay, you get an increase in the amplitude of the P wave. Okay. Your QT interval is prolonged. So remember, QT is measured from the onset of the QRS to the end of the T wave. That's your QT interval. It's prolonged, and this you can see your inverted T wave and your U wave. So this prolonged QT interval give you your polymorphic ventricular tachycardia, which is dangerous. So you can see these electrolyte abnormality can be dangerous. All right. So you get a polymorphic ventricular tachycardia, which can degenerate into ventricular fibrillation and kill you. All right. So be aware of that. Now, calcium. Calcium is also very important. So you can get a low calcium, and your surface ECG will help you with a low calcium. So with a low calcium, your QT interval is prolonged. So again, QT is from the onset of the QRS to the end of the T wave. So your QT interval is prolonged. When you measure it, it's prolonged. All right. So that is suggestive of hypocalcemia. Hypercalcemia now. So a high calcium, your QT interval is shortened. So it's the opposite to your hypo. The QT interval is shortened, and you will get what we call an Osborne wave. That's Osborne J wave. What the QT is usually a clincher. So you can see with a hypocalcemia, QT is prolonged. With hypercalcemia, the QT is shortened. See, this is sort of when you measure it, it's shortened. Okay. Okay. Also magnesium. Magnesium is also very important. So just like your hypokalemia, hypomagnesemia, low magnesium. So this is magnesium. A low magnesium can also give you a lot of problems. You're going to get prolonged PR. It's similar. Some of the changes are similar to your hyperkalemia, low potassium. So with the hypomagnesemia, you get this wide QRS, prolonged QT interval, and it will, when the QT is prolonged, you can get torsade de pointe. Okay, so hypomagnesemia, low magnesium. The main thing there is prolonged QT interval, decrease amplitude of your T wave, and torsades de pointe. So you get and these are fairly common now. Okay, so low magnesium So if the QT here is from there to there, you can see it's prolonged, and then it's from there to there is your QT, which is prolonged, and then it degenerates into this polymorphic ventricular tachycardia. So this polymorphic ventricular tachycardia is what we call torsades. This is a STORSAD, torsade the point, polymorphic ventricular tachycardia, which can degenerate through ventricular fibrillation and death. So hypomagnesemia. Then the last rhythm that we're going to look at is asystole. Asystole means no electrical activity, flat line, it's death. Okay, so this is actually a patient of mine. Um, so let me give you the story of this guy. This guy he has been having fainting spells for like 2 years, and so he came to the hospital and had one of his fainting spell, and we monitor him. We put him on a monitor because we never catch anything. So we put him, and he had one of his fainting spell, and this is what he did. So he had this long pause, which is essentially asystole, and you can count it to see. So this is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. So what you do, you count up all of that and you divide it by 5 and you'll get the amount of seconds. So he was asystolic for a lot of seconds. Okay, so we just put a pacemaker in and he's fine. He's doing fine. But anyway, so when someone is asystolic, they discontinues. It continues forever, and the heart stands still. If the heart stands still, you're going to be dead. So it's flatline. Okay. All right. So that concludes our ECG session. Okay.